Good morning, good afternoon, good evening. Welcome to a new episode of our interventional teaching YouTube videos. My name is Regina Bokenkamp. I'm the chairperson of the working group Intervention of the AEPC. And this series of educational videos is an initiative of the junior members of our working group in the time of pandemics, when teaching courses are very rare. We tried to use a master and apprentice approach because catheter intervention is a craft, and we are all craftsmen or craftwomen. So I want to introduce today's master, Daniel Velasco Sanchez from Leeds, who will inform us about retrieval techniques. And later on, our apprentice will be Mohammad Abumehdi from Evelina's Children's Hospital. Thanks to Linda Boschers from Canis, and who helps us a lot with the video and the organization of it all. And many thanks to Domenico Sirico, the junior representative of our working group. So, Daniel, the floor is yours.
Hello and welcome to this AEPC sponsored presentation. I am Dr. Daniel Velasco Sanchez, and I am a consultant in pediatric cardiology and congenital catheter interventions at the Leeds General Infirmary in the UK. My talk aims to touch on the different transcatheter techniques to remove lost cardiovascular foreign bodies, which are commonly used during congenital cardiac catheter procedures. Before I carry on, I would like to congratulate AEPC for this online initiative, which is addressed to trainees with an interest in this specialty, and to thank AEPC for the opportunity to contribute to it. I don't have any conflict of interest related to this topic. The presentation is based on colleagues and personal experience as well as literature review, and is intended to give a general overview of the topic. I strongly encourage everyone listening to this presentation to use it as a starting point and expand on the topic with the publications which are mentioned along the presentation. The presentation applies to procedures and techniques that can be applied in pediatric and adult patients indistinctively. The plan is to start the presentation with a quick introduction to the topic, followed by some general considerations and advice. Next, I will discuss the different retrieval materials available, followed by the specific retrieval techniques applied to the most commonly used devices. For simplicity, I will be using the term device and foreign cardiovascular body as interchangeable during the presentation. In the last 25 years, transcatheter procedures in congenital heart disease have evolved dramatically. It is now the first line of treatment when dealing with the majority of isolated intra and extracardiac shunt, significant residual postoperative lesions, and aortic and pulmonary valve lesions. During many of these procedures, devices, catheter, balloons, and wires are going to be used, all of them with the potential for suboptimal positioning, dislodgement, or rupture, leading to embolization. In addition, the number of children with various chronic disorders requiring long-term central venous access is increasing, and these catheters may fracture, embolize, requiring retrieval. With all in mind, it seems mandatory to be familiar with the decision-making process and the transcatheter techniques required to deal with these kind of situations. This 15-year review by Kudumula and colleagues from Birmingham Children's Hospital in the UK of transcatheter retrieval of cardiovascular devices in the pediatric age gives a general insight into the nature of the problem in terms of frequency, efficacy, and morbidity. And I've used it as a starting point. In their series, the overall embolization rate among the different devices varied between 0.5 and 3%. In their hands, retrieval was possible in up to 90% of the cases. Most frequently, embolization occurred within the first 48 hours after the procedure in up to 96% of the cases. Transcatheter retrieval attempts are not free of complications and morbidity, and as expected, they resulted in longer anesthetic times and radiation dose. In this series, the complication rate was 9%, and this included transient loss of peripheral pulses, significant bleeding requiring transfusion, and damage of the AV or VA valves. Other potential non-complications of embolized devices or the retrieval attempts include significant arrhythmias, central and peripheral vascular injury, thrombosis, and rarely they can lead to death. Of the total number of embolized devices, 60% were occluded devices such as coils, ASDs, PDAs, and VSD devices. Central line represented 20%, followed by stents and others at 10% respectively. In terms of the procedures, PDA occlusion was the clear winner, with just about 40% of the embolization cases being related to this procedure. When facing an embolized device, there are some general considerations to take into account. I think the first and most obvious one is to avoid embolization as much as possible. Pay attention to detail, be systematic when performing your procedures, be aware of the specific limitations of each device, and don't push these limitations at the beginning of your practice. Patients are more often stable, so there is time to think and plan. Embolized device and retrieval attempts, either transcatheter or surgical, are not free of complication. Therefore, a risk assessment has to be made between leave versus relocate versus catheter or surgical retrieval for each case. Think about your retrieval strategy, sheath size, additional vascular access. Try to think about the first plan, second plan, third plan is possible, and get your retrieval material ready. One of the most important advices that I like to give you is not to be afraid to ask for help, and this applies to junior and senior operator. I cannot stress enough the importance of asking for help. Retrieving a foreign body is not a personal vendetta, and a second experience pair of hands and brain will only increase your chances of being successful, only the patient benefit. There are also other specialists in your hospital who might have experience in retrieving devices such as vascular or interventional radiologists, and they might also have useful retrieval material that you don't usually stock. Think about requesting cross-match blood if you haven't done so before, in case you need it. If the embolization is recent, anticoagulation with continuous IV heparin to prevent thrombus formation might be reasonable, especially when there is a large material embolizing the left side of the heart while waiting to take the patient to the cath lab. It is easy to lose the sense of time during this procedure, so make sure you keep your ACT time at least above 200 seconds and that you check it regularly. Inform your surgical team about what is happening so they are aware in case they are needed. And for obvious reason, the use of biplane fluoro is always much preferred when trying to retrieve a device. And finally, and as a general rule, please do not attempt to retrieve unprotected devices across the heart, and as it is almost guaranteed that you will cause irreversible damage to one of the AV or VA valves, which will result in serious short and long-term consequences for the patient. Moving now to the retrieval materials available. These are basic range that every catheter lab has to store. This involves long sheath, snare, and grasping forceps. Also get to know what is available in other departments such as vascular and interventional radiology. I've used the material that we usually stock in our lab as a guide, but this can change widely, so they get to know your stock well and be familiar with its use. The good range of long sheath is probably the most used and goes up to 14 French with 75 centimeter length. The good flexor range are braided and more kink resistant, but remember that the tip is still soft and can unfold, complicating the retrieval process. The long gore dry seal sheath are a relatively new option. They are shorter compared to the long cook sheath at 65 centimeters, so they can be short in tall teenagers and adults, especially if you need to reach the distal PAs. They go up to 12. They go from 12 French up to 26 French with 2 French increments, because in our case, we do perform pediatric and adult cases. We store almost all the sizes. In pediatric only cath lab, the use of larger sizes is going to be limited, but still worth considering a limited selection of sizes. The dry seal sheaths are made of hydrophilic coating, so they're easily to introduce and advance. They are also kick resistant while maintaining some degree of flexibility. And the most important characteristic is one of the most important is they also have a balloon inflatable valve to reduce blood losses, and this is extremely useful when you need to advance several catheters or wires across the same sheath, which is often the case during a device retrieval case. Snare catheters are essential for device retrieval cases. They come in multiple different designs, but the most versatile and used ones are the gooseneck snares. And these are the only type that we store in our lab. They are available in different French sizes, catheters from micro catheter 2.3 French to 6 French, and different snare loop diameters ranging from 2 millimeters to 35 millimeters. Remember, the snare catheter are straight with a limited torque, but you can replace them for a different tip shaped catheter, such as Jenkins right, left, or guiding catheters, as long as they come in, you use the same French size, and they will improve your chances of grabbing the device. Forceps can be used to retrieve any foreign body, but you need to keep in mind the risk of vascular injury while trying to grab the device, or the potential to disrupt the device structure while trying to pull it inside the sheath. I think forceps are more useful and are more frequently used to provide stability to mobile devices, or to move a device to a location where it can be easily or more safely snare. Or they can also be used simultaneously with a snare catheter as an extra pulling retrieval force to bring the device inside the sheath. There are quite a few different types of transcatheter forceps, but the most useful ones are the myocardial biopsy forceps or the toothed forceps like the Maslanka. The myocardial forceps have the advantage that they are available as small as 3.3 French, so they can be used in smaller patients. However, the grasping force is limited. The Maslanka forceps are specifically designed to grasp and retrieve devices. The grasping force is stronger compared to the biopsy forceps, and they are designed with sharp teeth on the tip of the jaws to provide a reliable grip. However, their use is limited in smaller patients, as they require a minimum of 6 French sheath or a 7 French guiding catheter. This is an example for Maslanka forceps used to turn a 20 millimeter AVP2 device that embolizes in the left pulmonary artery. On this lateral view, we see the Maslanka forceps grabbing the distal disc of the device. The forceps not only allow us to rotate the device, which is not seen here, but it exposes the microcatheter, and so it allows us to turn the device and expose the microcatheter, but it also gave us a stability to snare the device in a much easier way. And now we're ready to talk about the specific techniques that can be used to retrieve devices. I've chosen to structure this part focus on the most frequent foreign bodies that will require retrieval and the different and most successful retrieval techniques that apply to each device. Different techniques can be used to retrieve the same device, and the same device can be used to retrieve multiple devices. Keep also in mind that you will most likely need to use several techniques during the same procedure before you are successful. So keep an open mind during these procedures, and I will say that be imaginative. I will begin with the more simple ones like coils, central lines, and rupture catheter balloons, followed by the different occluded devices. And I will finish with some remarks and tips about embolized stents. Coils, broken central catheters, and guide wires are almost always possible to retrieve with snare techniques. Small coils that embolize in the distal pulmonary circulation or in non-terminal systemic arteries are better left alone, as retrieval attempts can be more harmful than leaving them in situ or in place. Favor a detachable coil with control release system where possible, as they can be easily repositioned or retrieved if you're not pleased with the position. 3 mm diameter coils tend to embolize deep and distal into vessels, and they're often quite difficult to retrieve. So I would advise to limit their use when possible. The risk of damaging intracardiac structures or peripheral vascular damage when retrieving unprotected coils, catheter, or guide wires is lower compared to other devices, as they are usually soft and bendable. However, always avoid this if possible. There are multiple retrieval techniques that can be used to, but the most frequently ones are the ones listed here. For additional techniques, I recommend reading this detailed article by Rossi and colleagues. The proximal distal snare technique is the most frequently used and basic technique used to retrieve coils, catheter, guide wires, and devices. And this is one of the ends is accessible and can be a snare. The size of the loop snare has to be equal to or slightly smaller than the vessel diameter where the device has embolized. Once the device is a snare, it will bend, acquire a kink shape. So this has to be taken into account and make sure that the short or long sheath has a lumen which is at least double of the coil, catheter, or guide wire diameter. These are two examples of the techniques. This first one shows a typical and a straightforward snaring of the proximal tip of an embolized catheter in the main pulmonary artery. The second one is a case of an occlusion of an aortopulmonary collateral in the descending aorta. The first video shows a non-detachable coil that has prolapsed into the aorta. Still, part of the coil is partially inside the catheter. So to avoid distal embolization in the femoral arteries, where it can be more difficult to snare, the coil is snared in this position, and then is retrieved safely through a contralateral femoral artery short sheath. When a coil embolizes into a small vessel, the tips of the coil are not easily accessible, and the loop snare often doesn't have enough space to deploy. In those cases, the snaring technique is demonstrated on the left diagram. First, advance a catheter close to the coil and pass the coil with a guide wire. Advance the snare catheter beyond the coil, then retrieve the wire and exteriorize the snare distal to the coil. Retrieve the tip of the snare catheter proximally to the coil, leaving the snare distally. And at this point, you have to pull the snare and advance the catheter together. While doing this, you might snare one of the ends of the coil or the synthetic filaments that are often attached to coils to promote thrombosis. If this doesn't work, another option is to try and move the coil into a bigger arterial branch or venous, but usually arterial branch, where you're going to have more chances of snaring, like shown on the right diagram. To do this, advance and pass the coil with a microcatheter, for example, and advance a coronary wire over the microcatheter, then remove the microcatheter and advance a coronary balloon over the wire with a similar diameter of the vessel distal to the coil, then inflate the balloon and pull the balloon back carefully, making sure the coil is also coming back easily. In this case, it's wise to have another vascular access if this is possible, so you're still able to snare the coil while maintaining the catheter balloon in place to avoid the coil embolizing back to the same place. This balloon technique can be applied in other situations, like in this case, 15 balloon was inflated in the left inferior pulmonary lobe, preventing the device, in this case a large AVP2, to keep embolizing distally where it was not possible to snare. With the balloon inflated, the device stays stable in the proximal left pulmonary artery, where it was snared, and as we see in the images, and lately with the aid of a second snare, retrieved successfully through this gold seal sheath. When the catheter or guide wire don't have a free edge accessible to the loop snare, you have mainly two options. The first one is to create a second snare using a guide wire and a loop snare catheter, as shown in the picture on the right. You will need to advance a long sheath that will accommodate both the snare catheter and a second catheter that you will use to advance the guide wire. First, open the loop snare distally, and then a guide wire is passed across the other side through the catheter, and a snare with a snare loop, which is then tied around the guide wire. Once this has been completed, the whole complex is pulled inside the sheath. A last option will be to use a forceps. This is ideally best performed in a vessel large enough to allow the forceps just to open freely, reducing the risk of vascular damage. The fluoroscopy on the left is an example. In this case, the tips of the fracture central long line were not easily accessible. One was on the right ventricle, and the other one was very close to the insertion point in a very small left arm vein. The rupture catheter was retrieved in the innominate vein with biplane fluoro using a Maslanka forceps with no complications. Transversal balloon rupture during transcatheter balloon angioplasty, as shown in the picture on top, is a situation that you will face a few times during your career, and is well worth to spend some time. When this happens, the balloon tends to infall and become stuck in the tip of the sheath while trying to remove it. If this happens, these are the standard steps to follow to be able to retrieve the balloon. First, gain a second contralateral access, femoral access, and upsize the sheath at least 2 French when possible. Second, keep the balloon catheter in the common femoral vein or femoral artery and bring the wire into the bifurcation. Then snare the wire from the contralateral axis and exteriorize the wire, creating a veno-venous or arterial loop. Next, advance the balloon catheter towards forward into the contralateral sheath and externalize the balloon, applying some rotation to avoid the proximal end of the rupture balloon to get stuck again. The upsized contralateral sheath is usually enough to prevent this from happening. Once is externalized, cut the distal catheter balloon and retrieve the remaining catheter backwards through the initial sheath that was used for the procedure. In the next section, I'm going to talk about the embolized ASD occluder. Again, prevention is always preferred to device retrieval, so pay attention to detail and be systematic. Perform a careful measurement and sizing of the defect and good stability check. Don't rush and take time to evaluate device position. Beware of small or floppy inferoposterior rims. If absent or deficient inferoposterior rims, my advice is not to attempt device implantation, as this is likely to end up in embolization. If the device is trapped in the AV valves, ventricles, the patient is unstable, surgery is probably the better option. Additionally, if you have used the biggest device available, or if it's clear that the ASD will not be suitable for another transcatheter attempt, I think it's better to ask your surgical colleagues to remove the device and close the defect. Patients are almost invariably stable, so take your time to think and plan. Additional vascular access is not usually required, but as a rule, use the biggest available long sheath that is safe to use. At least 2 French bigger, but much better if 4 or more. Get your retrieval material ready, inform the surgical team, and ask for help to improve your chances of a successful and safe retrieval. There are different types of devices, each one with a particular engineering design, and this influences how to retrieve them. The most frequent techniques involve snaring the right atrial disc attachment mechanism. There are 3 main different types of mechanism: the pinball mechanism, like in the fibula and Seraflex devices, a macro screw, like in Amplatzer or Cocoon, and an eyelet in the Gore devices. My experience is essentially limited to the Amplatzer, Fibula Flex, and the Gore devices, but these are the most used devices in Europe, so I will focus on the techniques that you can apply to retrieve these 3. When dealing with an embolized Amplatzer, the first step, again, is to upsize the long sheath, 2 French or ideally 4 or more. Beveling the sheath tip, as shown in the top picture, is not required systematically, but can be very useful when trying to retrieve larger device which have larger micro screw. And this is the time to think about doing this, and I will show this in more detail in the next slides. If the device is mobile, it might be difficult to snare, or if the array screw is not facing the right way, then in these cases, it can be stabilized with a wire, a catheter, or a forceps, and you can also use the forceps to grab the device and move it somewhere else, or to turn it so it can be easier to snare. Once upsized, the long sheath can be advanced close to the as close as possible to the embolized device. Then advance a 5 to 25 millimeter gooseneck catheter as close as possible to the array micro screw. Replacing the snare catheter for a same French JR catheter, like in the inferior picture, is often helpful, as the distal shape of the JR catheter gives you more chances of engaging the array macro screw. Once the array macro screw is snared and the snare is secure, you can just pull the device inside the sheath, like in this example of an embolized unplugged septal occluder in the descending aorta. The array macro screw has already been snared and is pulled inside the long sheath without too much difficulty. However, pulling an unplugged device inside a sheath is not always as straightforward as in this case. A relatively common problem with the unplugged device is that the array macro screw doesn't align with the sheath and keeps latching at the orifice, making retrieval not possible. This problem is simulated in the video with a larger unplugged VSD device that, like in the case of ASD devices, has a larger micro screw. In these cases, and as demonstrated in the 3 inferior pictures, beveling allows the macro screw to align vertically better with the tip of the long sheath rather than remaining on a transfer position and getting stuck. Ideally, you have to do this at the beginning of the case, at the time of exchanging and upsizing the sheath. Otherwise, it means you'll have to detach the device from the snare and restart all over again. If still unable to introduce the micro screw at this point, you can try a few more tricks. The first one is shown on the left hand side video. The device is already snared, but keeps latching at the tip of the sheath when trying to pull it back. Retrieving the sheath backwards by pushing and pulling back the device along with some rotation of the sheath eventually allows the device to elongate a little and the micro screw to align with the sheath. Once this is done, the device can be easily pulled inside. A second trick involves elongating the device in the descending aorta or IVC, for example. You can appreciate this in the 2 pictures on the right-hand side. On the first one, you can see how elongation allows the micro screw to get a more vertical orientation with better alignment with the sheath compared to when the device is not elongated, as it tends to remain horizontal, as seen in the right-hand picture. Additionally, device elongation also reduces the resistance required for the device to get inside the sheath. Another technique to overcome this problem is the double snare technique, beautifully explained in this article from a South Korean team. The technique goes as follows. First, and once the micro screw is snared with a first snare catheter, a second snare is introduced over the first one as seen in the top image. Second, advance the snare, the second snare along the first one until it reaches the micro screw. Next, tight and secure the second snare distally to the first snare, like in picture 4. Once they are both secure, adjust the length of both snare catheters and pull the first snare slowly while pushing the second one. This will be enough to align the macro screw with the sheath, so it can be retrieved without latching of the tip on the tip of the sheath. The next ASD device is the Occlutech Fibula Flex 2. When it embolizes, this device is technically much more challenging to retrieve compared to the unplugged. This is because the array disc pinball doesn't provide enough grip to the snare catheter and tends to come off when attempting to retrieve the device inside the sheath, despite of appropriate upsizing. With the fibula flex to device, the single snare technique has been reported to have a failure of around 50%. A quick reminder is not to forget to secure the device after loading it into the delivery cable forceps. Otherwise, the device will come off the delivery cable forceps during implantation when pulling back the device from the LA into the right atrial septum. Similar to the Unplatzer, oversize the sheath, at least 2 French, but ideally more. Beveling is not really required as the array pin doesn't tend to latch on the tip of the sheath. Single snaring of the array pin can be successful, but this is probably only worth it to attempt in occluders of less than 16 millimeters. According to benchmark testing, devices larger than 16 French are not possible to retrieve with a single snare, even when using sheaths up to 18 French. And this is what usually happens when attempting a single snare technique with the fibula device, and is that repeatedly and frustratingly the snare comes off the array pin as seen in the video. To overcome this problem, there are different options. First, you can try and elongate the device in the IVC or aorta, and as this reduces the initial resistance required to introduce the device inside the sheath. The double snare technique described before has been reported to be reliable, and it has been shown to be successful even without the need to oversize the sheath. The use of the Maslanka forceps alone is another option. Bench testing using oversized sheaths has been proven to be possible, but only when grasping the device at the array pin or very close to it. The tip of the fibula flex delivery cable forces can be modified and shaped, and there are some successful reports of direct catching of the array pin with the cable forces, but this is not going to be possible in most of the cases. Even when applying correctly all these techniques, it's not unusual to end up in the situation shown in the video, where the device is partially retrieved inside the long sheath and the snare catheter is not enough to achieve complete retrieval. In this situation, using the fibula flex delivery cable to grasp the pin is a good and relatively straightforward option. Then you just have to lock the system and retrieve the device. On a similar way, you can also use the Maslanka forceps alone or in combination with a catheter snare. In my experience, when attempting to retrieve a large fibula flex device, you need to be ready to apply different techniques or a combination of them to be successful. This following case is a good example of device techniques applied to retrieve an array pin device. In this case, an occluded VSD device, which has the same pin mechanism as the ASD device. This is a 14-year-old patient, 48 kilograms, with an embolized 60 millimeter occluded VSD device in the right pulmonary artery. The first video in anteroposterior projection shows a 20 French dry seal sheath with the tip in the proximal RPA. Inside, there is a 10 French flexor sheath. Then there is a 4 French JR catheter with a 5 millimeter snare inside. All the system is kept stable and in place with a Landerquist wire positioned distal into the right middle lobe. The initial attempt involved snaring the right disc pin, which is easily done as the pin is facing the right direction in this case. Next, a clip shows the attempt to retrieve the device with the snare catheter along inside the dry seal sheath directly. Unfortunately, and as mentioned before, this is not usually sufficient, and it was the case, and the snare came off the pin, leaving the device free again in the main pulmonary artery. After some time and manipulation, the next video shows a second and more promising attempt to retrieve the device, this time using a double snare technique. The dry seal sheath tip has been pulled back into the MP as the blood pressure was not stable when the sheath was in the right pulmonary artery. first a 6 French 25mm gooseneck snare catheter is already securing to the right disc pin, and a second one is advanced over the first snare and is being secured into the right disc pin. Next, the device is then slowly pulled back using the 2 snare catheters into the tip of the sheath with some final adjustment of their length. So we are ready to pull the device inside the sheath. These next 2 videos are simultaneous AP and lateral projection. At this point, the right disc of the device is inside the long sheath, but despite the significant pulling of the 2 snare, the feeling is that they're going to slip off the pin. Keeping the 2 snare attached to the pin, a Maslanka forceps is then advanced to grasp the device to add traction force, and this is enough to bring the device inside the sheath successfully. And then pulling with both together, and finally the device is retrieved. Another good example of the use of a combination of techniques is this video of a 30mm fibula flex device that embolized in the right ventricular flow tract while attempting to close an ASD in a 29-year-old patient with an interrupted IVC using a right internal jugular vein approach. Here you see the device embolizing into the RVOT. A long sheath is advancing to the right ventricle, and the RA pin is successfully snared using a 2-snare technique. The first snare is implanted, and then followed by a second snare, which is nicely positioned just distally to the second snare. However, when trying to pull the device inside the sheath, the 2 snares came off the RA pin. Luckily, the RA pin remained inside the tip of the sheath, and at this point, the fibula flex delivery cable is advanced, and it is possible to capture the RA pin and lock the mechanism and retrieve the device. Compared to the self-expanding devices, the Gore cardioform device are very different, and to understand how to retrieve them is worth it to spend some time knowing their engineering characteristics. Both devices are made of platinum phenylnitrile wire frame covered by PTF, which deploys to create 2 discs that are kept together by a nitrile wire, which passes across from the left eyelet through the center of the device to the right eyelet, where the locking wire ends on a small loop. The PF4 occluder is mainly used to close PF4s, but can be used in secondary ASD up to 60mm. And it doesn't have a central waist to occlude the defect, while the ASD occluder is specifically designed to close secondary ASD up to 35mm, and is designed with a central waist which covers the ASD, while the right and left disc maintain the device stable. This picture showing more detail the Gore ASD occluder as it would look like once it's locked and implanted in the interrectal septum. The PF4 occluder looks almost similar. On the right hand side, there is a picture of the right disc with the right eyelet. The orange arrow shows the locking loop coming out the center of the eyelet, which is keeping the 2 discs together once the device is locked. The image on the left shows the LA disc. The locking wire originates here in the left eyelet and bends backwards, creating a little loop, not to be confused with the locking loop. This runs across the center of the device, coming out of the right eyelet as the locking loop. On the image on the center, you can see the fluoroscopic views of all this structure as seen in the pictures. The Gore company recommendations to retrieve the device are summarized here. First, upsize the sheath at least 2 French, but more the better. Do not attempt to retrieve a device with a forceps alone, and only use the forceps to stabilize the device. The forces can break the structure of the device and might result in the device breaking in fragments, which can then subsequently embolize. Snaring the array eyelet is preferred, as release the locking loop straight in the nitinol wire and the device, making retrieval into the upside sheath easier. This first video is a simulation where you can, that I made myself, where you can see a snare catheter grabbing the right disc eyelet. It is very important to snare the right eyelet as distal as possible and close to the disc, as otherwise you will not have enough support and the snare will come off the eyelet. As you pull the device, the locking loop, you can see how it unravels slowly, allowing the disc of the device to unlock and elongate so the device can be easily retrieved. You can also appreciate this on this real-time fluoro. First, the array eyelet is a snare and then pull inside the sheath. When pulling the array eyelet, you usually inside the sheath, you usually require some rotation of the sheath to allow the eyelet to get inside. Then the locking loop comes off and the device unravels inside the sheath. Snaring the left eyelet or central waist is possible, but it's more difficult to retrieve, and this doesn't unlock the device. To make this possible, you probably need quite a lot of traction, possibly use 2 snares and the largest sheath possible to be able to pull the whole device inside the sheath. The next chapter involves PDA occluders. Again, there are different brands and designs which can be used, but I will touch on the most frequently used. The Occlutech ADO2, ABP2, and unplugged piccolo occluder have an accessible macro screw that can be snared and retrieve previous upsizing of the sheath, ideally at least 2 French. It is worth it to give some attention to the unplugged piccolo occluder. This device is approved to be used in small babies, potentially down to 700 grams. Device retrieval of this device in small babies involves a whole set of challenges, as sheath upsizing is limited, and even small French sized sheath can cause significant hemodynamic instability or damage when advanced through the heart, to the point that in some cases retrieval is just not technically possible or is associated with significant complications. To illustrate this problem, this example of an ex-premature now weighing 2 kilograms with persistent respiratory support and a significant PDA, a 5/4 piccolo device was implanted but embolized to the right pulmonary artery soon after being released. All the videos are on lateral projections. After some attempts, the device is snared with a micro snare inside a 4 French JR catheter. There is also a 5 French long sheath low in the IVC, which cannot be seen in this video. The sheath had to be pulled back as previous attempts to advance it in the main pulmonary artery resulted in significant bradycardia and hypotension. The patient blood pressure only remains stable as long as only the JR catheter with the snare were in the pulmonary artery. The right-hand video shows how it was possible to partially pull one of the device's disc inside the JR catheter, but nothing more than this. At this point, and in a quick sequence, the 5 French sheath was carefully advanced over the JR catheter into the pulmonary artery, close to the tip of the JR catheter, to then successfully retrieve the device and JR catheter inside the sheath with no time for the patient to become unstable. The ADO1 device is probably the most widely used device to close PDAs. It does have a micro screw, but there are some caveats that you need to be aware. In the smaller ADO1 sizes up to 8/6, the micro screw is not accessible as it is enfolded inside the back end of the pulmonary end of the device, making the micro screw not accessible to a snare catheter. As seen in the top picture, to remove this size of ADO1, you will have to snare the central waist, and to do so, you'll have to upsize the sheath at least 4 French. In the ADO1 10/8 and above devices, the micro screw doesn't enfold, and it is possible to snare it and you would only require a minimum of 2 French upsizing, but always remember the better, the more the better. Next, a quick word about the VSD occluders. Similar to the 801 device, the smaller sizes of muscular and platzer VSD devices have a recessive microscrew that is less accessible to snaring. So the retrieval strategy for the muscular VSD devices is then similar to the strategy for an 801 device. The unplatzer membranous VSD occluder is basically out of use nowadays, but it does have a microscrew that can be snare. The Occlutech VSD occluder, as we have seen before, has the same pin mechanism as the fibula flex, and the retrieval techniques can be extrapolated. And last, some consideration about embolized stents. Retrieval of embolized stent is possible, but I have to say that in general, this is not a procedure for a junior consultant, as it requires experience and advanced catheter skills. There is such a large range of different stents, cover and cover, open cell, closed cell, hybrid, and situations that is impossible to cover them in too much of detail in this presentation, and most of the cases will require a case-by-case decision process. Going back to the article by Kudumula and colleagues, 75% of the cases involving embolized stent in the pediatric age were related to stenting of the left pulmonary artery. Unfortunately, embolized stents are not only challenging to retrieve, but transcatheter stent removal or replacement has an increased risk of complications, which can be serious and associated with long-term consequences. Careful evaluation of the potential risk of an incorrectly positioned stent left alone versus the possible complications associated with a retrieval or relocation attempt have to be balanced. Therefore, the most important decision that needs to be made when a stent is misplaced or embolized is leave versus relocate versus retrieve. Leave the stent where it's not going to cause any damage versus relocate the stent to somewhere where it will not cause any complications versus a transcatheter or surgical retrieval. A stent, like other devices, embolize more frequently at the time of the procedure. Getting the best wire position and not losing wire position gives you the best chances of dealing with an embolized or misplaced stent. In general, uncovered stent that embolize in the pulmonary arteries and migrate distally into small branches are better left alone, as they will not cause any significant long-term consequences. This video shows a stent that embolizes in the right inferior pulmonary lobe branch and has remained patent 6 years after the initial embolization with no associated complications. Non-deployed stents of any size can be usually retrieved by snaring. Oversizing the retrieval sheath as much as possible is mandatory in these cases. Deployed or non-deployed medium-size and coronary stent can be removed by collapsing them with 1 or 2 snares. Take into account that stents with hybrid designs might result in the snare getting tangled with the stent strands, and you won't be able to release the snare. So make sure you have a large sheath in those cases, or you risk ending on a complex surgical retrieval. This is an example of a 4-year patient, 18 kilograms, with a recurrent left pulmonary vein stenosis despite multiple previous balloon angioplasty. The 515 onyx coronary stent embolizing the abdominal aorta soon after implantation in the left inferior pulmonary veins, and you can see it moving up and down in the first video. Next, the stent was snared using a 4 French 10 mm loop snare, and it was partially collapsed inside the sheath. And finally, the stent was fully collapsed and removed into a 6 French long sheath, which was 2 French bigger than the recommended sheath for the undeployed stent. In the case of a large deployed stent, the best approach is to try and recapture with a catheter balloon and reimplant the stent somewhere safe, like descending aorta, or pulmonary arteries, IVC or SVC. An example of this scenario is this attempt of stenting a hypoplastic transversal with an LD max 36 mm stent that resulted in the stent slipping backwards into the ascending aorta. The wire position was stable in the ascending aorta, and this allowed to recapture the stent. with the same balloon, which was then carefully pulled back into the transverse arch. Following this, the stent was redilated with a bigger balloon, and this is the angiogram after this. And finally, another stent was was implanted to secure the final position. This was followed by a balloon angioplasty of the origin of the head and neck vessels to prevent future stenosis of thromboembolic events. This case, it shows the dexterity of the operator, but it has to be acknowledged that repositioning the stent in this case involves a non-negligible risk of dissection or damaging the aorta or the head and neck vessels. In this case, the only alternative option was surgical retrieval, which already involves significant risk related to the multiple patient comorbidity. So this is also something that has to be a factor occasionally in the decision making. How much risk do you take on those cases? And this is the end of the talk. I would like to show my gratitude to my colleagues from Leeds, who is now in the United States, Dr. Thompson, Dr. Bentham, Dr. Chevani from Glenfield Hospital, and the Gore Company for kindly allowing me to use their invaluable material for this presentation, and of course AEPC to be able to be part of this learning project. As the final remarks, I would like to remind the importance of focusing on preventing embolizations. Be methodic, don't rush, and do the required checks during the procedures to ensure that the result is optimal, and if not convinced by the result, retrieve the device when it's still possible. Be aware of the limitation for each device, and don't push the boundaries during the first 1 or 2 years of your practice to keep your confidence up and your patients safe. When possible, look out for help. 2 brains and 2 pairs of hands are always better to make the right decision for every patient and to have the best chances of being successful. In these cases, almost always the patient is going to be stable, so get ready, inform the surgical team, get your retrieval material out and available, and take some time to plan your strategy. It is not possible to cover all the details in 45 minutes, but I hope it gives you some insight into the techniques available in these sort of cases. And I will encourage everyone to read the articles which I've used to prepare this presentation, which are easily to find through the slides. And after this, I think it's the time for questions and comments from my colleague.
Okay. Thank you, Daniel, for this amazing presentation and very comprehensive. I think of course, nobody would like to face complications such as an embolized device, but you know, this is sometimes this happens, and is beyond our willing, and we need to be prepared to face it. So I think I believe that everyone has enjoyed your talk and your presentation, and among the others, for sure, juniors and young interventionists. They sure did. So speaking of which, as the junior counselor of the Interventional Working Group of AEPC, I would like to invite all the juniors which are interested in interventional catheterization to join our group, and to contact me. You will find the details in the description of the video, and of course to subscribe to the YouTube channel. But I don't want to waste any more time. We can go ahead for the Q&A's discussion. So I would like to invite Ryan to go ahead and to ask very difficult questions to our expert. Thank you.
Thank you, Domenico, and thank you for including me in this project, both Domenico and Regina. And Dr. Velasco Sanchez as well for doing such an excellent and comprehensive talk on retrieval techniques. To be honest, I don't have many questions because I think it's so comprehensive, and most of the questions are answered within the talk. But I had a couple that I managed to think about. So, Daniel, you mentioned a high rate of embolization of PDA devices. Do you have any comment on the reason why this may be, or any particular tips in prevention of embolized devices?
So I think that's from the article from Kudumula from Birmingham. Actually, I think if you look at the in particular to the PDA device embolization rate, if you look at the number of procedure and divided by the rate of by the number of the embolized device, actually it was one of the lowest. But if you look at all the embolized devices, then the most frequent devices that embolize were the PDA devices. That's just because PDA device occlusion is one of the most frequent procedures that we do. So obviously you're going to, these are higher numbers, so you're going to, in proportion, it's going to be in absolute numbers, you're going to have more embolized devices. But if I remember well, the rate of PDA embolization was one of the lowest, around 1%. And in terms of PDA, again, you know, PDA device occlusion is one of the most common procedures that we do, and I think is, you know, it's just a careful technique. Again, you know, if you always follow what we always teach you, get your angiogram at first. If you're not happy, repeat the angiograms. Make sure you have a good angiogram that you're going to be able to measure the device. Do an angiogram before releasing the device with the device still attached, and then once, and if you're happy with that one, then release and then check again. It's just, you know, just trying to be systematic. That's what I would recommend. Always be systematic. Then when you get older, then you start being less systematic, and then you think everything's fine, you rush, and this is when a lot of times mistakes can happen. And yeah, and that's the reality. That's the reality. But so yeah, does it answer the question?
Yeah, that's good. Thank you. And in your talk, you mentioned the loop snare technique. Do you have any recommendations on particular sheath sizes? Because you'd have to accommodate 2 catheters, for example, as well as the embolized device. I think in your talk, you allude to at least French sizes bigger when you're retrieving things in that sort of more traditional way. If you do use that loop snare technique, do you have a sort of rule for that?
I mean, the minimum sheath size, it has to be at least, you know, 1 French above. If you add the 2 French catheter size, at least 1 French above that. But obviously, because at the end of the day, the device is not going to interfere with the catheters, because the catheters are going to be already in the sheath when you're trying to retrieve the device inside the sheath. So that shouldn't be an issue. But again, you know, you always just have to go. The bigger you can go, always the better. Once you have the device snare and you're trying to pull it out, then, you know, then there's no chance to change the sheath. So always go the higher you can to begin with, and I will definitely prevent you from struggling to retrieve the device. But it's, you know, you're always going to be much higher. You're always going to be using maybe 6 French catheters. So, you know, 12 probably is going to be the bare minimum where you're going to be using that technique. But that's the general rule. So don't be afraid. Always go higher. The higher, the better. Okay.
Okay. And how about your experience with basket snares and multi-loop snares? Is it something you have much practice with, or maybe something you stayed away from?
Yeah, that might be a good, because each one, you know, again, with the material you use to retrieve device, the best thing is to get used to, you know, be comfortable to what you use. I'm not sure what the advantages of basket snares and the loop snares. Definitely the multi-loop. I think that's more of interventional radiology. They use it more than us. I've never used one, and we don't stock those, so I don't really have any experience on those.
No.
Anyone else, Domenico or Regina, do you have any experience with those?
This multi-loop, no. Most instances for us, a single loop snare is enough and was enough. So I haven't.
And same for me.
Okay, maybe it's just a sort of remnants of the literature. And how about heparinization, Daniel? Do you have a, you know, for example, here we tend to aim for ACTs above 250. Some places we used to just give heparin at the start of the case at a reasonable rate. But do you have a particular aim for your ACTs, or how much you heparinize, and do you increase the frequency anymore, given that you've got an embolized device?
So you mean when you're trying to retrieve an embolized device?
Well, I think from my somewhat limited experience, normally you would start them on heparin immediately as soon as you found out whatever device is embolized, depending on, I guess, what it is. But do you have, during the case, maybe, would you anticoagulate more?
No, I think just follow the standard anticoagulation route you normally use in the lab. So just go, you know, above 220 seconds ACT. And then just making sure that, you know, because those cases, it can become quite long and time can fly. And then you just have to make sure someone is always reminding you to check the ACTs. It's quite easy to lose a notion of time in those cases. And especially if you're working, you know, if you're working on the right side of the heart and it's no real risk of right to left shunt, then I will be a little more relaxed. But still, you know, it will do the same. But it will definitely. And if you have an embolized device in the left side of the heart, you will have to be a little more. How do you say? You just have to really pay attention just to avoid any more serious complications. But I will keep it as you know, the usual, like a standard.
Okay, so you wouldn't automatically go higher. Okay,
definitely check it, because you do forget. You know, it's not 1 hour procedure. It can easily become 2 hours procedure, and then you know you realize you've been with normal ACTs for an hour.
Okay, yeah, no, I think it's easy to get caught up in the moment, isn't it? And can I ask, so if you're retrieving embolized devices from the pulmonary arteries, or for example, an embolized PDA device, do you have any particular projections, or do you start quite straightforward AP?
So the standard, you know, first when you it depends, but once you're aiming to snare the device, so you have the snare close to the device, just always go orthogonal views. You have to try and you know, always use the biplane, which probably everybody now doing congenital has a biplane lab. So that's really helpful. It does save a lot of time, but always use orthogonal views. If you're aiming for a PDA or an ASD device, you know, if it's an Amplatz or an Occlutech or whatever device, just aim for just to try to profile the device and then try to get another view which is orthogonal to that one. So that's, you know, it gives you the best chances of knowing exactly where you are and be able to snare the device. Does it make sense?
Yeah, no, absolutely. So try not to be keep to the basic principles of angiography. Really.
Don't use an antero, you know, it doesn't have to be lateral or antero-posterior. Just whatever projection, it gives you a good profile of the ping, you know, if it's an ASD device, for example, and then just go 90 degrees to that one, and then you'll get your orthogonal views. And that's, you know, that's how it's going to be. Those are going to be the most useful ones.
Okay, thank you. The next one, I guess, is a little bit of a personal one for me, because we had a case a couple of years ago where we were trying to snare something back into the sheath. So we were able to snare the device and put it. We were trying to put it back into the sheath, but the snares and probably was that maybe the sheath was a bit small. So then we had to change to forceps to try and bring the device into the sheath. And again, the attachment from the forceps and the body of the catheter again snapped. So, like I said, I suspect it's probably because the sheath was not large enough. But is there any way that you would maybe go, for example, if you've already snared the device, is there any tips or tricks that you would use to maybe increase the size of the sheath, or do you just have to start again?
Well, that comes when we say the choice of upsizing at the beginning. You just always go the higher. Once you've snared the device or you grab it with a forceps, then if the sheath is not big enough, then you don't have other option apart from just releasing the device and then start it all over again. So that's why it's so important making the right choices at the beginning and not rushing, and and don't be scared to upsize as much as you can. It will save you a lot of time.
Yeah.
But the idea I just missed it was that the device wouldn't come with only partially.
So we could snare it and bring it to the mouth of the catheter. Yeah. But on pulling it in, again, probably because the sheath size was too small, the snare would snap, and the same happened with a sort of forceps device as well.
That you have to most of the time it's just the tip of the sheath that is folding in, so that's preventing the device to get in, and so it's a combination of both. If you but the only way to prevent that is just having the biggest sheath you can, and then using the 2 snare technique, even with the devices in, it will prove useful. It just give you that extra retrieval force to bring the device in. So it can be 2 snares or even the forceps and the snare at the same time. So I definitely try that before just releasing the device back and start it all over again.
Okay. So again, bigger is better. And then finally, this is a bit philosophical, I guess, but at what point do you sort of accept defeat and ask your surgical colleagues to help bail out?
That's a good question. It's quite a good question. When do you stop? Because again, these cases, they can go on, they can become quite long, quite often. It's not unusual. I've shown pictures that it look like, you've gone, you grab it and you took it out and it took 30 minutes. It's not true. It takes you sometimes hours. So you have to be patient. You have to be systematic. And then, the general rule, what you have to think is first, do I need to retrieve the device? Do I need to retrieve the device? Is this the bigger ASD device that I've used? Is it I'm going to be able to close this PDA with a bigger device, or so if there is no chances that you're going to be able to treat the patient with another device, or there's no other interventional option, then you might just think, anyway, this patient is going to need surgery. Why should I spend 2 hours trying to retrieve a device when I can actually send the patient to surgery, device retrieve, and then the patient treated, which is what is going to happen anyway. And then I guess and obviously if the patient has significant comorbidities, you have to take that into account. You might have to push longer to your limit. If the patient is a high-risk surgical candidate, then you might have to push yourself as much as you can, ask for help. And even sometimes, if the patient is stable and doesn't have, the device is not causing any compromise, stop and then come, the next day, if you can do that, with new ideas. And I guess if you're on a case and you've tried all the techniques and you've tried all the techniques and tips and tricks that you have, and it just doesn't work, then you just have to, accept that it's not going to work. But it's difficult. It's difficult to say, I'll stop. It can be difficult. This is enough, and then the patient, needs to go to surgery. So you have to balance all those things together, I guess.
Okay,
may I ask
thank you very much.
A question? In our center, we are implanting more and more Gore Cardioform ASD occluders during the last 2 years. And I realized, and also watching your presentation, I realized more that the possibilities to retrieve the GCA device are, I would say, less favorable compared to other ASD occluders. What is your idea? I mean, you mentioned that you cannot, or it is not recommendable to use forceps, for example. What's your comment? Do you think the same, or you're not worried about that?
So for the new Gore device for ASD, the Gore ASD device, we've been also using it for the last maybe 16 months or so. So yes, those devices are much more challenging to retrieve. This is probably the only device that Gore has actual recommendations. So those are the recommendations from Gore. I did approach Gore, and these are their actual recommendations. Obviously, the forces with the Gore, most likely you're going to grab the how it's called. It's not PTFE. The plastic material. So you're going to get one of the wires. So it's most likely when you're trying to retrieve with one of the wires that the wire either is going to break or the device is going to be completely deformed, and you're not going to be able to retrieve the device. So I mean, and it does make sense. I don't think that will work. You will get more into trouble. So it will be more to stabilize the device. And I think it was proven useful a few years ago. Just with the forceps, you stabilize the device, and then you can, you give you more chances to aim to the array. How it's called? Sorry, to the array ping.
The eyelet, yeah.
The eyelet, sorry, yeah, that's it, not the ping. But what I realized, I've never had to retrieve one, but I realized, you see those videos that were bench testing, so I did have a few devices, and it's not that easy as it seems. The snare has to be really very close to the disc on the eyelet, so the snare has to grasp the eyelet really close to the disc. If you're in the middle, it will just snap, and it doesn't come in. Once it's really so you have to really be pushing quite. The snare has to be really as closer to the disc, to the array disc. And then you'll be able to grab it there. Otherwise, it does. Yeah. When I try to do it a few times, it just comes off. The snare comes off. But I don't have any, real life experience. But from manipulating the device with the snares, that was my impression, that the only way it works is when it's very close to the array disc.
Okay, thank you.
Do you have any experience with?
Well, we embolized one GCA. Was big one. I think it was 42 millimeters in a 11-year-old patient, and this embolized. The problem is that it embolized into the tricuspid valve and got struck in the valve. So we managed to snare it, but we didn't have enough force to retrieve it. But we had only the possibility to keep it away from the valve, because she was not hemodynamically stable during this. Okay, so our fear was that the device was also trapped into some cords, and so in the end we tried to pull, but we didn't force too much. We just stabilized the patient and then sent to the surgical room with the long sheet still inside, with the device which was snared into the right atrium. Okay, so just to get the patient stable. So I don't know if this in our unsuccessful retrieve was because of the device strapped into the chordae, or because we couldn't apply too much force to the right atrium eyelet to get the device folded again. So this was our only experience. Yes.
Yes. Yeah, especially this one when it embolizes in the device, the core, the PFO or the AST, because of the loop of the locking loop, then it can easily get tangled in one of the cores. So definitely these ones, if they are in the right ventricle, and I've seen it before, send them to surgery because you do really risk damaging one of the AV valves.
Yeah. Okay.
I want to come back to this, what you called a philosophical or more, but it also is a practical question. And this is the question when to involve the surgical colleagues in a case when you are doing retrieval. I think it is worthwhile to do it pretty early, to discuss it with the surgeons and discuss what the interventional way to retrieve a device would be, and also what the risk of a surgical procedure would be, to make a weight decision early on, and not to wait too long and being confronted with a long procedure and damage on the way out, on the way when you try to retrieve and you get stuck and tangled. So my advice is discuss it early on and make a team decision how to retrieve the device.
Yeah, you're absolutely right. I think I did mention it at the beginning of the presentation. Is especially if you anticipate, you're going to anticipate that the patient, things could go wrong. Involve them as soon as possible. You don't want to be calling your surgical team at 8 p.m. in the afternoon, everybody's at home, and then something goes wrong, and then people help is far, and it will take time to get. So you're absolutely right.
Yeah. So if there are no more questions, I would like to thank everybody who made this possible today. And I hope very much that we see each other soon face to face in a congress or a fellow course, teaching course. But we have to watch carefully how the situation will develop. So thank you all, and see you next time.
Yes, looking forward to meet you in real life, not through Zoom.
Thank you all.
Thank you all.
Thank you.
Have
a nice day.
Goodbye.
Bye.
Have a nice evening.